A very good evening to one and all. I am Arpita, moderator from this session from the IGCP group. Today, the topic that we are going to present is psoriatic arthritis, challenges in diagnosis and multidisciplinary care. And yes, we have someone very eminent from this field to present this topic, none other than Dr. Ved Chaturvedi sir. And it's a pleasure for me to welcome sir and to introduce him to everyone in this platform. Sir, post MBBS, he has done his MD, then DM. Sir is a senior consultant at the Sir Gangaram Hospital. He is the vice president of the Asia Pacific Rheumatology League, the APLAR. And yes, of course, sir has many publications, many journals under his name, and many awards that he has received. But yes, with this very brief introduction of him, I would now request sir to please take over the session. Over to you, sir.
Thanks. Thank you so much. For audience, basically, I was one of the few first DM in the country. So I'm doing rheumatology for many years, and initially I was doing at this hospital. This is called Army Hospital, and this is now after retirement. I'm working in Gangaram Hospital. So I'll tell you my brief is to talk about today is psoriatic arthritis. And now, psoriatic arthritis, believe me, when I appeared for my DM examination, I was given a case. I had never seen a case of psoriatic arthritis. I was a physician in army, and we were more busy in cardiology, neurology. I never thought psoriasis is very important, and that too on top of it, psoriatic arthritis. I knew something psoriasis, but generally psoriasis was seen by skin specialists. So they gave me a case of psoriatic arthritis, and they asked me very, those questions which I thought they are all odd and useless. What is a plaque psoriasis? What is a psoriatic arthritis? And so basically, over a period of time, even when I did my DM, uh, look, in 1964, when our first prime minister, Shri Jawaharlal Nehru, he died. Till that time, it's not long back, the psoriatic arthritis, this word psoriatic arthritis came in 64. You can imagine. So, I got admission in 1971. So in 64, this term came to light in the horizon. So what is psoriatic arthritis? For this crowd, look, for rheumatologist crowd, I can talk so many things about psoriatic arthritis. But for this crowd, simple is to remember if somebody has a psoriasis and somebody has also arthritis, that is called psoriatic arthritis. Unfortunately, sometimes the psoriasis comes first, sometimes arthritis comes first, and if sometimes both comes first, it is easy to diagnose. So you must remember, it is very easy to diagnose if somebody has a psoriasis and has a arthritis. Most likely it is because of psoriasis. But suppose somebody has psoriasis only and he asks, will I develop arthritis also? Because patient is educated, he says, will I develop arthritis? So that is called as skin first, then becomes psoriasis. So what are those conditions? Look, psoriasis, we all know it's a skin disease. So then all scientists, uh, they they studied and did a lot of research, and it was found that if somebody has a nail involvement in psoriasis, then they get more arthritis. If somebody has scalp involvement, then they get more psoriasis. If somebody has a inverse psoriasis, that is in the tummy, in near the umbilicus, they get more arthritis. So basically, sometime people thought if somebody has a very severe psoriasis, he will get arthritis, which is not true. It is basically that, yes, sometimes skin lesion comes first, and almost about, if you ask me, the simultaneous presence of psoriasis and arthritis is about 60 to 70%. So suppose I have seen 100 patients in a day or in a month, 100 patients, about 60 to 70% patient will have both psoriasis and joint disease, which is easy to diagnose because the moment you have to ask only one question, भाई आपको कोई स्किन की बीमारी तो नहीं है, do you have any skin disease? Patient generally tells, I have, sir, I have a psoriasis, or I had some skin lesion which I have never bothered. So then you see it is psoriasis. So 60 to 70%. About 15% patient will have skin lesion first, then develop psoriasis. So I told you what are the most the hazardous skin lesion. As I said, somebody has a nail lesion, somebody has scalp lesion, somebody has inverse psoriasis. They have more chances of developing. Somebody has arthritis first. Now you tell me, if somebody has arthritis first, how you diagnose psoriasis? You don't know because patient says, no, I don't have psoriasis. So arthritis, if somebody, how we recognize it may be psoriatic arthritis, if somebody has a DIP joint involvement. So these are the DIP joints. Last, this is a PIP and MCP, PIP, and DIP. DIP is the last joint. So this is the last joint. This one. If these are joints are involved, then this is the major difference between rheumatoid arthritis and the psoriatic arthritis. DIP joint involvement is more. So that is number one. Number two is the somebody has a axial disease. Then it could be that he may be having psoriasis, especially asymmetrical lesion with some new bone formation. So that is how the uh, predominantly psoriatic arthritis is a peripheral arthritis. It's a peripheral arthritis. Uh, Peripheral arthritis, like rheumatoid arthritis, you have a small joint, large joints involvement. The hallmark is dactylitis, enthesitis. Now, what is dactylitis? What is enthesitis? Now, enthesitis is in what is anthesis? Like you know, myositis means inflammation of the muscle become tendon, and tendon further become more thinner, and they join the bone. That portion is called anthesis, and inflammation of that portion which is very thin and join the bone, that is called enthesitis. So that's why they have a lot of aches and pains here and there, and which we don't know. So all those sites, especially most prominent site of anthesis is heel is one. Then you have the costochondral junctions that they have, iliac bones, that is another area of the enthesitis. So many areas of anthesis, back, spine, dactylitis. Now this is a very interesting word, dactylitis. Dact means inflammation of the whole finger. So that is, it is, they look like, I'll show you the photograph later. The finger become like a sausage, the sausage digit. So that is called sausage digit, dactylitis. Yes, not only peripheral joints, sometimes the spine can also be involved in about 25 to 70% cases. So that is the how it is. So there are a few nail changes, and the presenting symptom is like arthritis only, so like pain, morning stiffness, that happens in rheumatoid arthritis also, and limitation of the movements. And the let me just increase, I can't see the enter the full screen, let me just make it. Yeah, now it is from my side, I think I am. Yeah. So that is how these patients. So I what I do, how I diagnose, I always ask about DIP joint involvement. The first thing I ask is, do you have psoriasis? He says, what is that? What is psoriasis? So I said, do you have any skin disease? So second question. So if he says, look, I don't have much skin disease, but I have something in my scalp, so then I see psoriatic lesion. Then I ask the heel pain. Then I ask the nail involvement. Tell me how many physicians ask the nail involvement. So you must ask the nail involvement, whether nails are involved or not. So that is very, very important. And then the backache. And especially all these are inflammatory in nature because they happen more in the morning. So if the patient says, look, Dr. Saab, I'm okay, but in the morning hours when I get up, I get a lot of heel pain. So that is the that is how it is diagnosed. Now, psoriatic arthritis is inflammatory arthritis, as I said, unlike osteoarthritis. Tell me, if somebody comes, your grandma, and has a pain in the knee, which is more not in the morning. Once they walk, suppose they say, okay, doctor, Sahab, when I climb stairs, I get pain. That is a mechanical pain, and that is called as the osteoarthritis. Unlike mechanical pain, it's an inflammatory pain. Now, inflammatory pain is more after rest, so they have more morning stiffness. So it's an inflammatory arthritis. डॉक्टर साहब, मैं सुबह सुबह मेरी तबीयत बड़ी खराब रहती है, सुबह सुबह मुझे अकड़ जाता है, फिर मैं चलता फिरता हूँ तो ठीक हो जाता है. So that is inflammatory arthritis. And if you do a rheumatoid factor, because moment you see arthritis, you see it is a rheumatoid arthritis, because everybody feels it is rheumatoid arthritis. So if you do a test, it comes negative for rheumatoid factor, then there are more likely chances that they may be having something psoriasis. And this is the prevalence, depends on different studies. Just suffices to remember, it is more common in Europe and US than Asia. Now, why it is this, we don't know, but there's a huge difference in the prevalence. Maybe because there are more colder countries or whatever, or maybe awareness is more, so they have more psoriasis, and Asia have a low prevalence. And this variation is due to ethnic differences, geographical differences, different characteristics of the patient, psoriasis, and type of diagnostic criteria. Also, different criteria are used. Indian, we have a, as it is, poor data everywhere. So this also, but the by and large burden in our is about is um, about 8.7%. So that is how the these are the joints which are involved. As I said, the joint involved can be large and small joints. And I always ask about the DIP joint involvement. Sometimes DIP joints are not involved. Does not mean he has a psoriasis. Patient will only present with knee arthritis and history of psoriasis with him or his family. So basically, knee can be involved, large joints, ankle joints can be involved, axial joints like sacroiliac joint can be involved, wrist like rheumatoid arthritis, shoulder, neck. But I'll give you tips. If somebody says, I know, डॉक्टर साहब मेरे को ना किसी ने, somebody has diagnosed me cervical, मैं तो cervical है मुझे. So you must ask, do you have any skin disease? Neck involvement is very common in the psoriasis. That is number one. Heel pain is more common in psoriasis. DIP joint involvement, as I said, and even axial. Uh, it causes joint damage. So if you really ask me, once you have diagnosed, it can result in damage in almost about 50% of patients. So you don't take it lightly. If you have diagnosed psoriatic arthritis, the soon within 2 years of diagnosis, there is a joint destruction. So that has to be prevented. So we have to diagnose it early. So that's very, very important. By the time psoriatic arthritis patients have been followed for more than 10 years, 50%, more than 55% have in deformed joints. So you can imagine, almost, if you've seen 100 patient, 50% patient will have disability. So you must treat it aggressively. A delay in diagnosis is there. There is significant delay everywhere, whether in India or abroad. Almost 50% of cases in primary care and secondary care clinics are unrecognized. Early recognition and treatment likely to result in better outcomes, like any other. Even a 6 month delay impact long-term joint damage. So idea is, basically this slide says you must diagnose early. Like any other disease, if you diagnose early, then it is always better. Need for early diagnosis, because as the disease become late, so they develop erosion, then they develop the deformities of the joints, and there becomes severe pain and disability. So that is how it goes. The if you Just a minute. Then psoriasis in our time when I was doing MBBS, I always thought it's a skin disease. Over a period of time, we learn first thing it's not only skin disease, it's autoimmune disease and causes systemic inflammation, and which can cause all those. So earlier when these reports came, we were not very impressed, but over a period of time doing rheumatology for many years, we realize yes, they have a strong association with obesity. Whenever patient comes of psoriasis, you must do a lipid profile. They have dyslipidemia, they are diabetic or insulin resistance, and if you see the liver, they have a non-alcoholic fatty liver disease. And cardiovascular comorbidity presents a major cause of death in psoriatic arthritis, followed by respiratory disease in cancer. Patients with psoriatic arthritis have about twofold increased risk of death. So basically, you don't consider it as a simple skin disease. It causes many problems, which is the most common which we see in our OPD is diabetes. So whenever psoriasis patient is there, I always say, "By diabetes to nahi hai?" He says, "No, sir, I don't have diabetes." So get a blood sugar. Then, "Arey, this is diabetes also." He says, "I have never got it done." Then lipid profile. No, no, doctor, sahab, my lipid profile is okay. But if you do a lipid profile, then it is highly deranged, and this high lipid, this dyslipidemia can lead to hypertension. It can lead to atherosclerosis and coronary disease. So that is a, so psoriasis is a systemic disease. Forget that it's a skin disease. That's a very important. So and it involves joint also. So diagnosis. So diagnosis is by history, as I said, by physical examination, imaging, and by lab investigation. As I said, laboratory investigation, rheumatoid factor is negative. There is no single gold standard test which can diagnose psoriasis. If somebody asks you, is there any test for psoriasis? There is no test for psoriasis. Rheumatoid factor, we get it done. It is negative. It, you suppose axial disease is there, then we do a HLA-B27 that is positive, about 40 to 50% patients. Imaging, you can see the X-ray, and you can see the erosions, you can see the destruction of joints, you can see the new bone formation. And physical examination, of course, is that you have a tenderness and the swelling of the joint and this and the limitation of the movement. And history, either he says I have a psoriasis, he might say this. You must know the common site of psoriasis. One is scalp, everybody knows. It is the extensor surface of the elbow is another area. Then umbilicus and all over this, the back and front. So he will say some skin disease. Maybe you are lucky if some skin specialist has already diagnosed it. So psoriasis, that is the, this is a famous Casper criteria. Now, if you forget about the name, it was published in Arthritis Rheumatism 2006. And so simple that you have a joint disease and you have some evidence of psoriasis. So how? So, so this is a joint disease. The joint can be involved, spine can be involved, or ligaments can be involved, and at least 3 points from the following. Like if somebody has a joint disease and have psoriasis, then it is very important. डॉक्टर साहब मुझे psoriasis भी है और मेरे scalp में psoriasis है, then you can immediately diagnose, and it is given 2 points. So 2 points, it has given more weightage. You forget about points. It has been given more weightage if somebody has a current psoriasis. Personal history of psoriasis. Doctor, मुझे I had a psoriasis 10 years back. Or a family history of psoriasis. Yes, doctor, my father had psoriasis. So they have been also given importance. Typical nail dystrophy, nail changes has been given. This thing, how, what are the nail changes? They can be pitting, they can be hyperkeratosis, there can be onycholysis. Negative rheumatoid factor, 1 point has been given. Dactylitis has been given, either current dactylitis or previous episode. Previous episode में डॉक्टर साहब मेरा एक उंगली फूल गया था पहले. So that is important. And a new bone formation is also important. So that is how these are the, this how you diagnose. So some patient comes with a joint disease And he says, Doctor Saab, I have my rheumatoid factor is negative. So he has 1 point. And you get X-ray, there's a new one formation. So it become 2 points. So that's very, very important to know that small thing matters. Another step was mole and right class. This classification came when in 90s 5 in 1973, uh, but we used to read in 95 because they were so famous, even so relevant today. You can say what are the types of psoriasis, or what are the classification how of the arthritis means, what are the phenotype of arthritis. So they can have a DIP joint involvement. Actually, that is what we learn in MBBS, that psoriasis means DIP joint involvement. But they can present as a symmetrical polyarthritis, exactly like rheumatoid arthritis. So you have a typical rheumatoid arthritis, small joints involvement, large joints involvement, morning stiffness, looks like rheumatoid arthritis, but rheumatoid factor is negative. And he says, I have a history of psoriasis, or my mother had a psoriasis, or when you do X-ray, there's a newborn formation. So that all, so you have to distinguish it from the rheumatoid arthritis. Or somebody has a asymmetrical oligoarthritis, means just one or two joints involvement, maybe two knee, one ankle. Oligoarticular means less than 5, and polyarticular means more than 5. And predominantly axial involvement, means sacroiliac joint involvement. So they will only come with backache. डॉक्टर साहब, आई हैव बैकएक, मेरे बहुत होता है, और भाई तुमको कोई स्किन की प्रॉब्लम? यस सर, आई हैव अ psoriasis also. So they are predominantly axial involvement, like ankylosing spondylitis, and sometimes arthritis mutilans. I had just seen one patient in my life, arthritis mutilans. One patient had come from Nepal, Dr. Mother, and she had every joint was totally gone. So it mutilates the joints, all joints gone. And I had given anti-TNF, and they become, uh, I could not diagnose, they didn't have psoriasis also, but my diagnosis was that she has a psoriatic arthritis. Because of arthritis mutilans, so much destruction of a joint, this disease can give rise to more than rheumatoid arthritis, in fact. So these are the types you must remember. This is exactly like, you. This is a dactylitis which I was talking about. This is enthesitis. This is arthritis mutilans, means a lot of joints involved and damage to the joint. The spondylitis we know, and the distal psoriatic arthritis. So that is the, uh, then is the, uh, frequency, relative frequency. How much is the, what is the frequency? If you really ask me, rheumatoid type of presentation, polyarticular, it is not as common as oligoarticular. So maximum patient you will get oligoarticular, means one knee, two knee, one ankle. Oligoarticular, less than 5 joints in an irregular fashion, asymmetrical fashion. That is the commonest presentation, followed by polyarticular presentation, and of course DIP joint, and the, we see a lot of spondyloarthritis because of our interest. And of course arthritis mutilans is very, very rare. I had just seen one patient in my whole 35 years career of rheumatology. So this is psoriatic arthritis. So basically involvement of DIP joint. See the DIP joints involvement. This is psoriasis, even nail changes. This is symmetrical polyarticulate disease with lot of, looks like rheumatoid arthritis, but DIP joint is involvement. So if somebody asks you in the examination that what is this, if a picture is given, since the DIP joint is involved and there is some skin lesion here, probably it's a case of psoriatic arthritis. And this is arthritis mutilans. Basically, see how this is, even one finger has been amputated. So this, all joints have totally gone within a short span of time. This is called arthritis mutilans. And this is dactylitis. Whole finger is swollen. This like a sausage digit. So this is a typical hallmark of psoriasis. And this is enthesitis involving the insertion of Achilles tendon. So this is Achilles tendon, uh, and this is inserted into the calcaneum, and there's an enthesitis here. So that is how the it is diagnosed. And again dactylitis. This is dactylitis C, mutilans C, and this is normal. This is synovitis, DIP joint involvement. Again dactylitis, whole this thing, and sometimes ankylosis even, and mutilans means totally gone. So see the X-ray, see the X-ray. All the DIP joints are so severely affected. So that is the and other joints also, but DIP joints especially. So that is very very important. Most of the time, wrist joint is not involved. So wrist joint involved more in rheumatoid arthritis. So that is how we recognize difference between rheumatoid arthritis and psoriasis. This we can leave not for this crowd. Basically the nail involvement, if you see, this is the this is the nail involvement in the psoriasis. So when the nails are involved, generally DIP joints are involved. So that is you must remember. And this is the uh, this is sorry. Now, for a beginner, you must ask your colleague in the dermatology how to recognize psoriasis. What is a plaque lesion? So this is what is a psoriatic plaque. I'm not a dermatologist, but I learn from my friends in the in dermatology, and still I feel sometimes that I can't recognize a skin lesion. Even if I recognize, I must get a confirmation from a dermatologist that it is psoriasis, because I'm very sure similar type of the psoriatic plaque can be seen. This plaque lesion can be seen in many other diseases also. So especially keratoderma and others, so that they must differentiate. So X-ray, I told you that if you see a DIP joint involvement, then it goes more in favor of the then severe joint destruction, this erosive changes, and sparing of the MCP joints, the metacarpophalangeal joints. See, the MCP joints are not involved. So in MCP joints are not involved. The moment you see MCP joint and wrist joint is more involved in rheumatoid arthritis. So basically, how I remember that these are the proximal joints, these are distal joints. The proximal joints are the wrist and MCP, they are not involved, while the distal joints are involved. DIP and PIP, they are involved in the psoriasis. Uh, Radiographic changes, erosions, joint damage, bone resorption, and bone proliferation. So there is the hallmark you must remember is simultaneous presence of bone resorption and bone formation. That you must remember. That is how it is. Then if you see, you can see the erosions. Even if you see the Doppler signals, you can see the Doppler signal in the DIP joint. See the erosions also. Nail changes, basically this is all by diagnosed by our skin colleagues. Sometime as a physician, it is very difficult to differentiate, is it a fungal uh, or it is a psoriasis. So these are the characteristic nail changes in psoriatic arthritis. They are characterized by ridging and pitting, onycholysis, yellow nail margins. So nail margins become yellow, and dystrophic hyperkeratosis is seen in the psoriasis. And spine can have a unilateral sacroiliitis or gygophyseal fusion or skip lesions of cenocyte, not symmetrical like ankylosing spondylitis. They have skip lesion and atlantoaxial subluxation. So Euler recommendation for treatment for these diseases is, what is the main target? So you must take a target what you are treating. The treatment is complete remission. CR is complete remission. LDA means low disease activity. So this is our target. You must have a complete remission or low disease target. It's an inflammatory disease, so use the anti-inflammatory drug. If a peripheral arthritis, you can use the same drugs like rheumatoid arthritis. You can use methotrexate, leftomide, sulfasalazine, and you can use local steroid for a joint disease or a low uh, systemic steroid, low dose. There's a bridge therapy as we do for rheumatoid arthritis. So you start, somebody has arthritis, you start some drugs like methotrexate, but methotrexate is going to take time. It is going to take about 8 weeks to be effective. So you use low dose steroid, which is called bridge therapy. You can use biologics, TNF inhibitors, like rheumatoid arthritis is well established. If our methotrexate and sulfasalazine and leftomide they fail, IL 17 inhibitors came almost about 4 or 5 years back. We are using it quite frequently, especially recommendation is that TNF therapy is inappropriate or is contraindicated. So TNF still remains the first choice. Uh, the then if the PD4 inhibitors can also be used, PD4 inhibitors like apremilast, advantage of is the oral drugs, and the oral drugs are less costly also. So that is a apremilast is very costly in Japan and USA, but in India it is quite cheaper. Uh, and anti-TNF, of course, used for axial disease, and anti-IL-17. For enthesitis and dactylitis, it is a biological demand. So you must remember, for a common physician, you must remember, if some psoriatic arthritis patient is there, use a drug, same drug as used for rheumatoid arthritis. Use you use methotrexate, leftomide, sulfasalazine. They also, your skin lesions also, they heal. So if you start methotrexate, skin lesions will also go, arthritis will also go. If somebody has axial disease, not peripheral disease, of course the treatment of choice is anti-TNF biologics, where methotrexate and leftomide they don't work. Sometimes sulfasalazine works, people say, but as per literature, it is only the biologics which will work. So the severity, I don't think so. We should have much in this slide. Just remember the mild psoriatic arthritis, moderate and severe. So basically, number of affected joints, if they are more the number of joints, is severity, mild, moderate, severe. And the radiological finding, if there are none, and if one erosion, and the severe erosion when there are more than five erosions with joint destruction and ankylosis and joint space narrowing and loss of function. If there is a none to mild, then moderate and severe, there are more than four swollen or tender joints and function is impaired. Quality of life, when the minimal effect, moderate effect, severe patient cannot perform major daily tasks without pain or dysfunction, you can imagine. So there is a large impact on physical and mental function. Patient evaluation, we can skip it. Previous, we can skip this. Just remember this. Basically, there's a mild disease and there's a severe disease. So as these are the drugs which are used. So use NSAIDs, use steroid, use methotrexate, sulfasalazine. You can use cyclosporin, or you can use biologics like etanercept, infliximab, golimumab, adalimumab. And these are PD4 inhibitors like apremilast, or now you can use secukinumab, which is available for last 5 years, and ustekinumab, which was not available, but I think now ustekinumab is being launched in the country within 1 or 2 months. So that is, there's a specific for psoriasis. That is how the GRAPPA is a organization association which is working for psoriatic research. So it's a group, has a basically working on for the psoriatic arthritis. And GRAPPA recommendation is if somebody has a peripheral arthritis, as I said, you can use all these drugs which you're using for rheumatoid arthritis. Um, you can also use NSAIDs, oral steroid, intraarticular apremilast. For peripheral arthritis, if they don't respond to these drugs, then you can use TNF inhibitors and the apremilast. Or if peripheral arthritis, if axial disease is there, then you can use biologics, which I already told you. Enthesitis, TNF. Dactylitis, TNF. And for a skin lesion, topical therapy can be used, methotrexate can be used, TNF can be used, any drug, IL-20, IL-17. For nail psoriasis, it is a, you don't, methotrexate and sulfasalazine, leflamide, they won't work. It is a TNF inhibitors and IL-12 and 23, they will work. So you must remember, somebody with nail psoriasis, he's not going to respond to the methotrexate and all. We have to use the biologics. So that is very, very important. Yes, beside topical therapy can be used. So yes, sometimes there are reports that methotrexate and leflamide also works, but the drug strong recommendation is for TNF and the so nail psoriasis is this. ULAR recommendations basically remains the same as rheumatoid arthritis. No need of cramming it up. Simply remember that you initially use the NSAIDs and the conventional synthetic drugs, like conventional, like you use methotrexate, or leflamide or sulfasalazine. And if they don't work, if one drug does not work, then use the combination of both. If they also don't work, then you can use the biologics. In biologics, you can, TNF is preferred. Otherwise, IL-17, apremilast is on the same footing. For axial disease, you don't have to use they won't work, neither methotrexate nor sulfasalazine. What will work is a TNF inhibitors, or what will work is the anti-IL-17. So that is how the psoriatic arthritis is the. So basically, this we have discussed. uh, if you asked, a lot of papers say that methotrexate does not have a very uh, important study to prove it, because methotrexate is an old drug. Nobody has done studies, but they have done studies with anti-TNF. That's why you see the anti-TNF evidence is there. It does not mean if sometime evidence is not there that they don't work. We know that they work. So methotrexate works, sulfasalazine works, leflamide works, cyclosporin works, anti-TNF works, and yes, there are a lot of studies on anti-TNF and IL-12-23, because they are latest drugs and there are a lot of studies are available. A lot of sponsors are also available. For methotrexate and sulfasalazine, you will hardly get any sponsors to do it. The uh, so this we can skip. Methotrexate. The methotrexate is basically is a drug which is commonly prescribed for psoriatic arthritis. There is little evidence to support, though, although mechanism of action is like rheumatoid arthritis only. They inhibit the dihydrofolate reductase and lymphocyte proliferation. And yes, of course, we should be cautious about the cytopenia and the rise of SGPT. Methotrexate is a very good drug, and there are a lot of studies are available for the rheumatoid arthritis, and some studies for which I think this is not the forum to discuss these studies. Now, biologics is the use for SRSS. These are biologics, especially anti-TNF, and these are the biologics which there is significant improvement in arthritis, psoriasis, enthesitis, and dactylitis. Anti-TNF therapy has really revolutionized the treatment of psoriatic arthritis. So TNF inhibitors, up to 40% of patients do not respond to TNF inhibitors. So you used anti-TNF and they don't respond, or they don't tolerate, then what to do? So then came the other drugs like this. So there is unmet need. If the methotrexate is also not working, leflamide is not working, combination is not working, anti-TNF is not working, then came the other drugs like, which I am going to show. There are people who are not very satisfied. So sometimes cost of the drug, safety, and people say, no, we don't want to use. So that is the, so newer targets came is the IL-17. IL-17 is a cytokine like TNF, which is seem to be high in the synovial fluid. So then you can use the drug against the IL-17. The drug is secukinumab, popularly available from now. Secukinumab, yes, day for yesterday on Sunday, it is launched by Reliance, Indian generic, Indian biosimilar. So it is no, I'm sorry, I'm mixing up. No, no, not this. Secukinumab is still not available. It is only available by the Novartis. Is Secukinumab is available, but the biosimilar has not been made. So this is a drug which we are using it, IL-17. So this is the IL-17. They are the proof of IL-17. These are studies which is with that they, if you, they your skin lesion, joint lesion, and they are really effective drugs. So these are the studies which are available for IL-17, which I am not going to discuss about these studies. But yes, of course, there are future one, future two studies. Must remember that there are some good studies of IL-17. The drug is called secukinumab. The dose for skin is higher, 300 milligram. For arthritis, the dose is less, 150 milligram. And there are long-term and short-term trials are available for the secukinumab. So basically, not only short-term, the long-term data is also available for. These are the studies which is available for almost for secukinumab provides sustained improvement in the sign and symptom of active psoriasis. So 3 years data is available, 5 years data is available, and now probably 7 years data is also available. So these are the ACR responses, various responses. So basically, this is a 2 years data that yes, they inhibit the structural progression, and this is a basically comparison with the adalimumab. It is as good as adalimumab or maybe better, and this is 24 weeks and 100. So the long-term data of secukinumab is available. Favorable safety profile. Secukinumab or IL-17 has no tuberculosis, hardly. So tuberculosis with anti-TNF is more common than secukinumab, but secukinumab can cause fungal infection. So that is the, so basically, and almost zero injection site reaction. So very low immunogenicity, very very important. And yes, sometimes patient can have little nasopharyngitis or URTI. So that is the uh, you must remember. I think this is the last one or two slides. So this is again the long term data in the for the IL-17. Our own experience. This old slide we have used now almost about 300 patient. At that time we use for ankylosing spondylitis, psoriatic arthritis. We don't have a single one patient had fungal infection. So we use 150 milligram for the psoriatic arthritis. So that is the. So thank you so much. I think I have finished, and uh, I'm fine with if some questions are there. The most important question, if I am in the crowd, will ask is there any difference of treating psoriasis and psoriatic arthritis? If you really ask me, there's hardly any difference in treating psoriatic arthritis. The methotrexate, leflunomide, sulfasalazine is used for psoriasis also, psoriatic arthritis also. Anti-TNF drugs are also used for psoriasis, and the IL-17 drugs like secukinumab are used, and now stectinumab, which has come. So both drugs are used because psoriasis itself, whether joints involved or not, psoriasis should be considered as systemic inflammation because of the comorbidities. Because even if they go to a skin specialist, a dermatologist nowadays are very very um, uh, they know that yes, it is associated with diabetes, it is with dyslipidemias, it is associated with many other insulin resistance. So we all should be aware that it's not only a simple skin disease, it's a autoimmune disease which can involve multiple system including joints. Thank you so much.
Thank you, sir. Thank you so much. As usual, a very nice presentation. So, meanwhile, we have received a few questions. The first question that has come from Abhiraj Anita, I would like to show you the question is psoriasis in scalp means what sign can be seen in the scalp, sir?
Look, I'm not a dermatologist. What sign can be seen in the scalp that you ask a dermatologist that how the psoriasis, what sign? Those that's why typically I have not discussed also. And frankly speaking, my own knowledge about psoriasis of the skin is not as bright as it should be. I know about arthritis more, but I'll read it. And for me, that what is the? I'm very sure Anita must be a maybe a dermatologist, so they may be knowing about more about these signs of the psoriasis, like nails and some those oil drop sign and all, which I'm neither I'm keen to learn, but I'll be happy if somebody can discuss.
Right, sir. Another question is what are the main diagnostic challenges in distinguishing psoriatic arthritis from the other inflammatory arthritis such as the rheumatoid arthritis?
Yeah,
Mine's
that's
only
very very
seeing the skin
important.
lesions. Yes, sir.
Yeah,
Continue, please.
as I said in the beginning, it is something like you have a fever. Now fever has many causes, so arthritis has many causes. The differential diagnosis of arthritis, if somebody comes with the arthritis, so we always ask what are the joints involved. So joints involved in rheumatoid arthritis, the wrist joint, MCP joints, and PIP joints. While these two joints, wrist and these joints, the MCP joints, are spared in psoriasis, then what are the joints involved in psoriasis? Is the DIP joints is the never involved in rheumatoid arthritis, and PIP joints are also commonly involved the in the psoriasis. So that is how one is the distribution. Another is symmetry. If both hands are involved, this is called symmetrical distribution. It is more common in rheumatoid arthritis than the psoriatic arthritis. Then the suppose axial disease is there. So axial disease is not common. It's unknown, unheard in rheumatoid arthritis, while the SI joint is involved in in psoriasis, and is the arthritis mutilans type of picture is hardly seen. Generally, even if a oligoarthritis presentation is there in rheumatoid arthritis, they gradually become polyarticular. And of course, arthritis, rheumatoid factor is positive in almost 70 to 90% patients of rheumatoid arthritis, which is classically negative for in the ankylosing spondylitis. So that very very important thing you must see, that the rheumatoid arthritis is rheumatoid factor positive, while psoriasis is rheumatoid factor negative.
Right, sir.
Sometimes psoriasis can be actually B27 positive. If axial disease there, almost 40% patient will have a HLA-B27 positivity.
So another question from Abhiraj Anita is bilateral involvement of TIP-JT joint, I guess, in psoriatic arthritis.
Yes, it is not a absolute. It's not that that if you asymmetry does not mean it's absolute asymmetry, that you will have always only one joint and the one. So there can be a symmetrical arthritis also of DIP joint involvement. Yes, very rarely the DIP joint involvement can be there in rheumatoid also, but it's extremely rare. I must have seen one or two patients. I have not seen about these, but DIP joint by symmetrical involvement is very well known in psoriasis. So just suffices to remember that GIP joints are involved in psoriasis, which is not involved in rheumatoid arthritis. But DIP joint can be involved in other diseases, like it is involved. It can be involved in SPA. There are other SPA conditions where DIP joints can be involved. Osteoarthritis, because Haberdon's node looks like a there can be a you can be confused that it is a DIP joint arthritis, which is not a DIP joint arthritis. So, but classically we teach DIP joints are involved in psoriasis and osteoarthritis. But actually speaking, that is not a arthritis, that is a Haberden's node, that is in the osteoarthritis. But for this level, we must remember that DIP joints are involved in psoriasis and osteoarthritis.
Thank you, sir, from my side, and also thanks a lot from Abhiraj
Thanks,
Anita.
thanks. I think as it is, one patient is lying on for joint injection, waiting for since long. Thank you so much, and
Thank you, sir. Thank you so
thanks.
much for your precious time. Thank you so much, sir.
Bye.
Thank you.
Bye.
Thanks to all the audiences for joining in. Thank you all. We are closing the
And
session now.
thanks, Anita, to ask these questions. Let me also read. It's not that I know everything. I will also read some scalp signs or something.
Right. Thank you.
Okay.
Thank you so much, sir, once again. Thank you.
Okay. Bye.